Hi class, welcome to Unit 6. We are going to start off by talking about assessment and management of patients with rheumatic disorders. And let's get started. So this is a kind of a catch-all phrase. It encompasses autoimmune, degenerative, inflammatory, and systemic conditions. These conditions affect the joints, muscles, soft tissues. There's a ton of them, and I'm not expecting you to be intimately familiar with all 100 types. It's just not realistic. The things that they have in common is the problems that they cause. They cause limitations in mobility and activities of daily living, sleep issues, pain, fatigue. It's really very hard to live daily with these types of limitations, and it can slowly progress to organ failure and ultimately cause death. There are some common ones, like clinical features specific, like we're going to talk about rheumatoid arthritis and pain. It's commonly, when it's a RA type disease, it's marked by periods where they feel better and then they get worse. And it's classified by how many joints are affected. Mono means one, poly means more than one. And is it inflammatory or non-inflammatory? So there's usually some distinct characteristics. There's usually inflammation, an autoimmunity component, and then degeneration. And then it's got some common symptoms. You're going to see pain, joint swelling, movement that's limited, stiffness, weakness, and fatigue. There's some health history that we need to have in the back of our mind. What do we need to assess for in these patients? And if you stop and think about it, it's just common sense. How do they walk? How do they stand? How do they get around? Do they have any deformities, abnormalities in movement that we need to address in order to make them safe? When did things start happening? Does it run in the family? Is there a hereditary component? Is there any other comorbidities that complicate this disease progression or make it more difficult to treat? All these things are considerations. There are some diagnostics that we can do. Table 38-1 has more information. Common ones are, your standard x-rays, a CT, MRI, that sort of thing. Arthrography is just looking at that joint specifically. There are some nursing considerations, some specific nursing diagnoses that are going to be applicable for these patients. And most of them go hand in hand with what we do to treat them. So pain, we're going to give them anti-inflammatory meds, analgesics, provide comfort measures. For fatigue, we're going to explain, techniques that help them conserve energy, like taking rest breaks between activities. For impaired mobility, we're going to assess, do they need some physical therapy, occupational therapy to help encourage their independence and make them as most mobile as they possibly can? Self-care deficit, do they need help figuring out where their weaknesses, where their strengths are, encouragement to do what they can, and then facilitate with like assistive devices that help them become more independent? And then do we need to put them in touch with some community agencies? So there's diffuse connective tissue diseases that falls in this branch. And again, it gets better, it gets worse, and it's immunologic in basis. Common ones are, the one that I mentioned already is rheumatoid arthritis, lupus, scleroderma, Raynaud's, or Sjogren's syndrome is a disorder where the immune system kind of attacks the moisture because the most common symptoms is dry mouth and dry eyes. It usually, Sjogren doesn't come alone. Usually it's accompanied by like other disorders, but it primarily affects like the mucous membranes and moisture secreting, that sort of thing. Lupus is a little bit more complicated. We're not really going to get into lupus, but again, all of these are autoimmune disorders. So like with RA and lupus, we're going to use corticosteroids, anti-inflammatories, to try and manage that inflammation and the autoimmune or the immune system response. This slide here, rheumatoid arthritis is a chronic inflammatory disease. It's caused by a combination of genetic and environmental factors. The key symptom is inflamed, swollen joints. And that inflammation and swelling, it actually causes and is developed by the fact that there's destruction of connective tissue and synovial membranes within the joints. Those joints get weakened, and that's kind of what leads to dislocation and permanent deformity. This condition does get worse with physical or emotional stress. And like I said, inflamed, swollen joints, tenderness, stiffness, all of them in the joints. It's usually, they usually report moderate to severe pain in the morning and stiffness that lasts longer than 30 minutes. And there's a ton of information on this slide, so I would take your time and kind of look at that. On the left-hand side, it's got the treatments. On the right-hand side, it's got those clinical manifestations. In the middle, it's got how do we diagnose it. So usually we do some labs. There is a serum rheumatoid factor they can test positive for. They are usually going to have an elevated ESR, which remember is a measurement of inflammation in the body. They're going to have an elevated C-reactive protein and a positive RH factor as well. For circling back to the treatment, we're going to use aspirin therapy. That's an NSAID that we can use. We can use COX-2 inhibitors. Remember back in pharm with aspirin though, a sign of overdose is tinnitus or ringing in the ears, and that NSAIDs are notorious for causing GI problems, GI upset, and even progressing to gastrointestinal bleeding. Okay. So those are some key things. The next slide is just a picture of that classic deformity that happens with RA. And then the next slide are those common features. What goes hand in hand with these problems? And then what do we need to teach the patients? We need to teach them how to care for themselves, how to deal with the exacerbations, what meds do they need to take, how to cope, manage, how to deal with stress, because remember, stress is going to make it worse for them. Are there any dietary plans that we need to put in place, any community resources? So it's really taking care of the whole patient. And then one thing I wanted to throw in here, and I'm not sure it's included in your book, but it should fall in this, is gout. Gout, and this slide, it has a picture of gout versus rheumatoid arthritis. They're very, very different. Gout is a systemic disease where these uric acid crystals deposit into the joint and sometimes other tissues, and that causes pain, redness, swelling. It can be intermittent, it can be acute, it can be chronic. It's a common and complex form of arthritis, and it can affect anybody. It's characterized by sudden, severe attacks of pain, swelling, redness, and tenderness in the joints. A lot of times it's the big toe. Those urate crystals can form when they have too much uric acid in the blood, and our body produces uric acid when it breaks down purines. It's a substance that's naturally found in our body, but there's certain foods that contain purines. For example, steak, organ meats, seafood, alcoholic beverages, stuff that's fermented like sauerkraut, beer, drinks that are sweetened with fruit sugar, fructose. All of those should be restricted in a patient that has gout because it's going to create more uric acid and it's going to make their pain worse. So what normally happens is that uric acid dissolves in our blood and then is passed through the kidneys in our urine. But when our body produces too much or our kidneys aren't getting rid of enough, that's when gout can happen. It builds up and it forms like these sharp little needle-like crystals in joints and surrounding tissue. And so another important education point is increased fluid intake unless it's contraindicated. So generally we say like 2 liters a day because this can help them from developing kidney stones. That's a complication that can happen with gout. We also prescribe 2 key meds that are listed on the slide, allopurinol and colchicine. We will also use anti-inflammatories, analgesics, and hot or cold treatment as well. Okay, so that's kind of the big bullet points with gout that you need to be familiar with and know. And let's move forward and talk about musculoskeletal disorders. Okay, so there are some common conditions that happen in the upper extremities that you need to be familiar with. I'll tell you one thing I had to look up because I've never heard of it before, and that is joint mice. Never heard of it. There's a picture of the slide just because I thought it was very, very interesting. It's little tiny fractures that dislodge pieces of cartilage and it forms loose bodies. And if you open it up, those are some pictures of what it looks like. I just thought that was very interesting. I'm not going to test you on joint mice. I just thought it was cool to look at. So that's my side note on this slide. So some more common problems that we're going to focus on are bursitis. Bursitis is a painful condition that affects the small fluid-filled sacs that cushion our bones, tendons, and muscles near our joints. Bursitis occurs when those little sacs, which are called bursae, they become inflamed. The most common places for this to happen are in the shoulder, the elbow, and the hip. Like sometimes people call it like tennis elbow. I don't know if any of you guys have heard of that. It can be, tennis elbow can also be tendonitis though too. So it's kind of a layman's non-specific term. So bursitis occurs most often at joints that perform repetitive motion. The symptoms of bursitis are pain, swelling, stiffness, and the common areas are knees, shoulders, elbows, hips. Let's see. Treatment. How we treat it: rest, ice, pain relievers. Surgery is rarely needed for bursitis. So let's contrast that with tendonitis. That is inflammation or irritation of a tendon. And remember, tendons are those thick, fibrous cords that attach muscle to the bone. So again, it's got the same background. It's overusage causing irritation and inflammation of that tendon. And so the treatment is NSAIDs, corticosteroids, physical therapy. Then we've got the ganglion. That is a benign cyst that's usually painless on palpation, but they can cause joint discomfort. That lesion can rapidly appear and then disappear. It's kind of weird. The impingement carpal tunnel syndrome, I think I talk about that on the next slide. So let's talk this. So Tinel's sign. It's a way to detect irritated nerves. It's performed by lightly tapping over the nerve, and it will cause a sensation of tingling, or people will say like pins and needles. And carpal tunnel syndrome occurs when the median nerve that runs from the forearm to the palm of the hand, it becomes pressed or squeezed at the wrist. That carpal tunnel is a narrow ridgeway of ligaments and bones that houses that nerve and the tendons that bend our fingers. And so when if it becomes thickened or irritated or swelling occurs, sometimes numbness, weakness, pain in the wrist and hand, or even occasionally the forearm and the arm can happen. This is probably one of the most common, like entrapment, what we call that, because of the nerve being compressed. Then we've got the Dupuytren Contracture, and I am not confident that I'm saying that correctly. It is a slowly progressive thickening of the palmar fascia, and that results in the contracture of the fourth and fifth fingers. Those fingers that are affected can't be straightened completely, which can make everyday activities very, very complicated. So that's that contracture. All right, let's talk nursing care. So what if they've got one of these problems and they do determine that surgery is needed? Usually correcting these type of problems is an outpatient procedure. So as I learned in the previous unit, patient education is really important. So is our neurovascular assessments, and we're going to talk about this again and again in this recording. So neurovasculars are super important. We also need to tell the patient the signs and symptoms to report to us with neurovascular assessment. Pain control, obviously, prevention of infection, how to help them with their ADLs while they recover, and how do we promote that independence. So let's talk neurovascular assessment. The 6 P's is another way to say it. I think I have another slide that I've got it like that. So color. It should be pink. What do they need to report? Pallor, cyanosis, redness, or discoloration. Monitor temperature. It should be warm. If it's unusually cool or warmer than normal, they've got to report that. Pain. What do they have to report? Pain that is worse on passive motion, or pain that doesn't get better when we give it medications like analgesics. Movement. Can they move it normally? If they have alteration in movement that we haven't told them that's going to happen, they need to report it. Sensation. Do they have any tingling, numbness? Paresthesia is the alteration in sensation. So like maybe when they touch it, it feels funny, that sort of thing. Pulses. Are they diminished or absent distally? Because those can be symptoms of a blood clot. And then our cap refill, that's our perfusion. Nail bed should blanch in 3 to 5 seconds. So if any of these things go wrong, these are what we need to report to the healthcare provider, because it means that they may be experiencing a complication. Okay, so let's switch down to the feet. So some of them you guys have probably heard. I'm going to touch on a couple of them. The hallux valgus, is a deformity where the great toe drifts laterally at the joint. Hammer toe is when the second toe bends upward. Both of these can be painful. Morton's neuroma is a small tumor that grows in the digital nerve of the foot. People describe it like they feel like there's a rock in their shoe. This one does require surgical removal of the tumor. Then we've got plantar fasciitis, which is very painful, and it's inflammation of the plantar fascia, which is located in the arch of the foot. This is most commonly seen in middle-aged and older adults, obese individuals, and athletes, especially runners. This plantar fasciitis accounts for 10% of all running injuries. And then the next slide, I've got some pictures of the hammer toe, the claw foot, the hallus valgus, by its common name, a bunion, and they hurt. Let's see. Then if they are a surgical candidate and they're going to have surgery to repair their problem, we follow the same principles as we've already talked about with the hand surgery. There is a chart in your textbook 41-4. We do need to take a look at how are they going to get around in their home while they're in that healing process. So that means we have to prepare them but prior to discharge so that they'll be able to walk a specific distance or do a number of stairs safely while they're recovering. Okay, so like I said, I'm going to talk about neurovascular assessment a lot. So post-surgically, we are going to do our neurovascular assessment. We're going to tell them what signs and symptoms to look for and what to report, how to help manage their pain, lots of patient education, improve their mobility, measures to prevent infection. So these are all key things, and we're going to talk about these a little bit more in later on in this recording, so that's why I'm just touching on it now. One thing that I want to touch base on specifically is osteoarthritis. And this slide shows you a picture of a normal joint versus an osteoarthritic joint. What is happening is there's a progressive deterioration of the articular cartilage. The cause isn't known, but we do have some known risk factors. They are trauma, aging, obesity, genetics, and smoking. Osteoarthritis is a non-inflammatory disease process. Rheumatoid arthritis is an inflammatory disease process. So what are the signs and symptoms of osteoarthritis? Joint pain that diminishes after rest and intensifies with activity early on. Then as it progresses, pain occurs with slight motion or even at rest. It is aggravated by temperature and humidity changes. You will have joint swelling, crepitus, and a limited range of motion. These people will have difficulty getting up after prolonged sitting. We will use NSAIDs, acetaminophen, topicals, muscle relaxers if they have muscle spasms. This is more common in the back. We can use corticosteroid injections, positioning, warm, cold therapy, and we do want to encourage these people to continue with their activity, but they should stop if their activity gives them pain. Okay, so from there, let's talk osteoporosis. It is very, very prevalent. It's a disease of the bones. It happens when a person loses too much bones, makes too little bone, or a combination of both. So as a result, the bones become weak and they can break from like a minor fall, or if severe cases, from simple actions like sneezing or bumping into furniture. Osteoporosis literally means a porous bone. If we looked at healthy bone under a microscope, you could see it's like a honeycomb. With osteoporosis, the holes and spaces in the honeycomb are much bigger than what they should be and what they are in a healthy bone. So that means the bones have lost density or mass, and the bone structure, the bone tissue has become abnormal. This can be very painful. So whenever you're taking care of a patient with osteoporosis, make sure you're moving them with care. So that would be providing support with a draw sheet, counting down, like, okay, we're going to move on the count of 3. We're going to move in 1, 2, 3. Let's move. When we discharge these patients to home, we have to teach them a lot about fall precaution. Tell them they need to be careful about throw rugs, toys, small pets. We do want these folks to exercise. The ideal exercise is walking at least 3 times a week. And another good one is swimming because it's low impact. This slide just shows you the spinal changes that occur with age. And so a normal spine at age 40 and osteoporotic changes that happen like around 60 and 70. So you can lose a fair amount of height over time with this condition. They also can result in something called a dowager hump. And that's kind of the last picture. You can see how her face is kind of pointing more downward, and that upper thoracic area is kind of curved upward. That's what we call a dowager hump. So to prevent this, what do we need to do? Calcium alone doesn't work. They've got to have calcium plus vitamin D, and do weight-bearing exercises like walking, light hand weights. Who's at risk for this problem? Thin white women, people with previous fractures, people who drink a lot of diet cola, and people that smoke. And we have found that older women who've taken hormone replacement therapy like estrogen actually have a decreased risk of osteoporosis. So I think that's why the perimenopause phase is when we see so many of these changes become more pronounced, because as women, we no longer have the protective qualities of estrogen the way we do when we're younger. Okay, so this is just a really cool picture of a bone density and the larger holes in that honeycomb structure. The lab tests we're going to do, of course, are calcium and vitamin D levels. Remember that calcium and phosphorus have an inverse relationship, so we may check phosphorus levels as well. We can do conventional x-rays that can show bone density loss, but it has to be a significant loss before it shows up in an x-ray. The other test that we do is a DEXA scan, D-E-X-A. That's the most common tool for measuring bone density. Most physicians recommend that women in their 40s have a baseline screening, and then that way later scans can detect changes. And a DEXA scan is painless, and it emits less radiation than a chest x-ray. So this slide shows you those risk factors in segmented form, genetically. Thin, white females of Caucasian or even Asian ancestry, they are at risk. Advanced age is another one. low calcium, low vitamin D, high phosphate. Those are your carbonated beverages. Remember what I was talking about with the diet colas? So yeah, that's some bad news for all of us if we like to have a lot of soda. Prevention, so balanced diet, high in calcium and vitamin D throughout our life. So that means starting now. If necessary, use calcium supplements, but you want to take in divided doses and ideally with some vitamin C. It helps with the absorption. We want those weight-bearing exercises. Walking 3 times a week. Ideally, we'd be not having any soda, especially diet soda. And then preventing injury would be huge as well. So what are we going to do for treat it? The one I want to touch base on is biphosphonates. That is really common once people have the osteoporosis diagnosis or they've noticed thinning in their bone. And that's medications like Fosamax or Fosamax, alendronate. I'm going to spell it for you. ALENDRONATE is Fosamax. And it's a biphosphonate. Some rules that you have to know. You have to take it 30 minutes before eating for the day. You have to drink it with a large glass of water, and they have to be able to stay upright for 30 minutes after taking it. And you do not take it at the same time as calcium. And this medication is potent and will help increase bone mass. Let's see. Nursing process, it's kind of self-explanatory. Is there a family history? What's your calcium intake? How do you exercise? Are you postmenopausal? Do you use corticosteroids as well as smoking, alcohol, and caffeine? All of those will also increase your risk of osteoporosis. And are they having any symptoms like back pain? Physical assessment, pretty straightforward. Nursing diagnosis, pretty straightforward. Our goal is to make them knowledgeable, relieve any pain, relieve any bowel elimination problems, and don't have them break anything else. So what are we going to do specifically? High fiber diet, increase fluids, stool softeners, physical activity, pain management, hot cold therapy, back rubs, supportive mattresses. All these things are helpful to get the best and the most mobility and function. Okay, so then I wanted to just touch base on osteomalacia. This one is a weakening of the bones due to problems with bone formation or the bone building process. It's not the same as osteoporosis, which is a weakening of the living bone that's already been formed and is being remodeled. The most common reason for osteomalacia is the lack of vitamin D. Vitamin D is an important nutrient that helps us absorb calcium in the stomach. It also helps maintain calcium and phosphate levels for proper bone formation. So be sure that you take a look at that. How do we treat it? Treat the underlying problem. If it is malabsorption, we're going to give them high-dose vitamin D and calcium. If it's a kidney problem, we're going to give them calcitrol. And those are really the key points with osteomalacia. You don't see that diagnosis nearly as much as you do osteoporosis. Then there is Paget's disease. It is a disease of some localized bones. It's not super common. It is a little bit more common in men, and the risk does increase with age, and it seems to run in families. What happens is excessive bone is resorption, um, and that leaves the bone weak and highly vascular, and we don't know why this happens. And this disease is painful. It causes some deformities, pain, warmth, and tenderness. So in a nutshell, what happens is this disease causes bones to grow large and weak. You can have it in any bones, but it is most common in the spine, pelvis, skull, or legs. It can affect one or several bones, but it doesn't affect the whole skeleton. The bones that are affected by Paget's break more easily, and it can lead to other health problems. If you do have a family history, younger couples need to have genetic testing done and may need counseling. And like I said, this is a really painful disease, so pain management is important as well. From there, we've got septic arthritis, infectious arthritis. Usually people that are of advanced age. It's usually a single joint. It presents with warm, pain, swollen, and you can't move it as well as you normally can. They may have chills, fevers, and low white blood cell count or high blood cell count, depending on how bad it is. Initially high, and then if it gets really bad, your body poops out. Let's see. So what we usually do is we usually aspirate a little bit of the fluid to see what is growing in there and then treat it with an appropriate antibiotic. Then there's osteomyelitis. That is infection in the bone, not a joint. It is a bone infection. We usually treat it with IV antibiotics, and we have to make sure that we cover any open wounds. If someone has osteomyelitis, we have to use contact precautions with wound drainage. So you've got to use PPE, gloves, gown. It's an infection of the bone, and it can occur in any age group. Let's see. Usually it has a skin ulceration, and then that skin ulceration goes all the way through down to the bone, and that's where the real infection process is going on. We have to use IV antibiotics usually because osteomyelitis is so deep that oral antibiotics aren't going to be effective to get down into the bone vasculature and deliver that medicine. Usually MRSA is the pretty most common culprit for causing osteomyelitis. There are some risk factors. Open fractures or wounds that go all the way down to the bone, absolutely, you can develop osteomyelitis for that. We would use like wound debridement to try and minimize that, but it can still happen. It can be acute or chronic. With chronic, they may have just a low-grade fever, not super high. And we do have to watch them carefully for adverse reactions and complication from antibiotic therapy because IV antibiotic therapy is very potent. Nursing diagnosis-wise, acute pain, impaired physical mobility, risks for extension of the infection, so they could actually have an abscess form. Our care, prevention is ideal. We do want to relieve their pain, control and eradicate the infection, and make them knowledgeable about what happened, what we're doing about it. These are just some good nursing interventions. I'm not going to go into that great a detail. Let's see. We typically will be administering the IV antibiotic therapy. So that's when your 5+5 rights come into play. You need to look every IV antibiotic up, check for compatibility, adverse effects, onset, any hypersensitivity reactions. We need to look at liver and kidney function to make sure they can properly metabolize and excrete any antibiotic. We also need to look and see if they have adverse effects like nephrotoxicity. So if they're on IV antibiotics for weeks, we need to be continually watching that renal function to make sure that we're not poisoning their kidneys at the same time as we're trying to treat an infection. And so sometimes we do peaks and troughs with these IV antibiotics to check to see if they're at a therapeutic safe level, and then monitoring of kidney function as well. Okay, so then let's talk benign bone tumors. So they're often asymptomatic. They can be discovered on like a routine x-ray or as a cause of a fracture. The tumor type is based upon the tissue that is affected. So osteogenic tumors means osteo is from the bone. We can also have primary tumors. Those ones, like osteo means primary is from the bone. Chondrogenic tumor means from cartilage. So primary bone tumors occur most often in people age 10 to 30 and make up a small amount of the cancers. Metastatic lesions occur most often occur in older age groups and account for most bone cancers. So primary bone tumors in young people, not super common. Metastatic lesions are far more common in older adults. One lab test that can immediately indicate that a cancer has metastasized to the bone is an elevated calcium level, and that is due to calcium literally leaking out of the bone. One thing I want to touch base on is osteosarcoma. It's the most common, most fatal, and it typically metastasizes to the lungs within 2 years of treatment. It's twice as common in males than in females. And high-risk people are people that have had previous exposure to radiation. Then we've got secondary. So secondary means it started somewhere else and moved to the bone. Primary means it started in the bone. Okay, so this secondary bone tumors, metastatic type, are more common than primary bone tumors. So usually it starts in the kidney or the lung or the breast and then moves to the bone. There are more common locations to find them. They're listed on this slide. Treatment is usually palliative because now you're dealing with cancer tumors in more than one location. So if you are caring for a patient with a bone tumor, you should assess the following that's listed on this slide. If they're going to go to the OR for removal, whether it's for cure or palliative, these are the things you need to assess. Notice on there white blood cell count and serum calcium level. Because we're dealing with the bone, calcium levels can give us a lot of information. So, and we also want to watch them closely for signs and symptoms of hypercalcemia. What could go wrong? They could have some delayed wound healing, some nutritional deficiencies, of course, infection, and of course, hypercalcemia. What are our goals listed on this slide? What is our care? Our care is similar to that of those for any orthopedic surgery. prevention of further fractures, support the affected extremity at all times, handle it gently. There may be external supports or fixation devices that may be required in order to keep everything aligned up. We have to restrict their weight bearing and their activity depending on the site of the surgical site, and then use assistive devices safely. What are we going to do? We're going to promote nutrition, oral care, hydration, and strict aseptic technique. We do not want these folks to get an infection on top of recovering from a bone tumor surgery. Okay, so this is really where I think we kind of get into a lot of the nursing interventions. Up to this point, a lot of it's been some background information, some assessment information, general medical diagnosis, what are we going to do to treat it. So this is kind of when we switch gears a little bit. When we talk about injuries of the musculoskeletal system, we talk a little bit more about the hands-on stuff. So this slide is nice because it just has some definitions, so be sure to read this slide. What do we do for these conditions? We do rest, ice, compression, elevation, immobilization, and anti-inflammatory medications. Then we move on to fractures. Okay, what happens if a bone has been broken? Well, there's some different types. You can have closed or a simple fracture, and that means there's no break in the skin. You can also have an open or a compound complex fracture. What that means is it's open to the bone. So a complete fracture means the break is across the entire width of the bone. An incomplete fracture does not divide the bone. An open or compound fracture, skin surface is open. A closed or simple fracture, there's no visible wound. Then you've got pathologic, a spontaneous fracture. That could happen with minimal trauma for someone that say they have osteoporosis. Fatigue or stress, you can have excessive strain or trauma, and that can cause a fracture. So back here, if we don't take care of this, it could progress to the bone and cause injury. This next slide shows you some pictures of all these different fractures. What I'd like you to take away is it is important to prioritize one that is open or compound. The reason why is because with an open or a compound fracture, the skin is open and it poses an increased risk for infection. And to prevent infection, we must keep that area covered, clean, and dried. Okay, so what happens when we've got a fracture? What are the signs and symptoms that are going to be evident in our patient? Well, they're going to have acute pain. They're not going to be able to use whatever is broken. It may look deformed. It may not align up. Shorten of this extremity. That is a classic hip fracture symptom. If someone has broken their hip, one leg will be shorter than the other and the foot will be turned outward a little bit. That is the classic hip fracture sign. Crepitus. Crepitus is that kind of crinkly grating noise. That means it's not stable, so we need to stabilize it. They could have swelling discolorations. We diagnose fractures based on their symptoms and getting an x-ray. And most commonly, your patient is going to report an injury that occurred to that area. So what do we do first? We immobilize the body part, whether that's by splinting. The distal and proximal joints have to be supported and immobilized. So if you're ever like repositioning a patient and you hear a grating noise that is coming from a bone, you must immobilize that fracture. We can also cast it. We have to assess that neurovascular status before and after splinting to make sure that nothing is being compressed or cut off. And if it is an open fracture, we've got to get that covered with a sterile dressing, and we do not reduce fractures. That is a physician-only intervention. So here it is again. Let's do our neurovascular assessment. Let's assess for peripheral neurovascular dysfunction. So we're going to assess circulation, sensation, motion. Avoid flexing it. Maintain positions that promote effective neurovascular function. Tell them to report numbness, tingling, coldness, pain that's not relieved by analgesia. And safety. You have to ambulate. You have to stick to your restrictions in order for these fractures to heal properly the first time. Okay, so let's talk some terminology. If we reduce a fracture, we are restoring the fracture fragments to how they're supposed to be anatomically aligned and positioned. So that's why it's not the nurse's job. What we do is we just immobilize so that no further friction or damage can occur. And so when they do a reduction, they can do an open or a close. Close uses manipulation and manual. Traction could be used. Open, they're going to use a fixation device. So that means they're going in surgically and placing pins, wires, screws, plates, that sort of thing. Or they can do immobilization, which is your casting, your splints, that sort of thing. There are some key things with each of these corrections that I want you to think about. So if they're getting a cast, circulation issues like swelling, pale, cool skin, you have to try to elevate the casted extremity above the heart and then reassess. Sometime with the cast, when they first put it on, the swelling was so much that like a day or two after, their cast is too loose because the swelling went down, and that means they need a new cast. And with any type of manipulation, whether it's closed or open, I want you to think when we do our neurovascular assessment, we have to be assessing for something called compartment syndrome. Compartment syndrome is a serious condition in which increased pressure within one or more of the compartments reduce circulation to an area. And a compartment is an area in the body in which muscles, blood vessels, and nerves are contained within our fascia. This is an emergency situation and requires surgery to alleviate it. And we're going to talk about this again, but I just want to plant the seed early. The next slide here, these are just some different techniques that we have for internal fixation. So your bones, or excuse me, your pins, your screws, your plates, all those types of things. And then, okay, what can affect how well a fracture heals? Well, if they aren't immobilized properly, if they don't have good blood flow, if they've experienced multiple trauma, if they have extensive bone loss, infection, if they're not adhering to their restrictions, if there's some sort of a bone malignancy, some medications or smoking, older ages, and then some disease processes. All of these things are stuff that we have to assess for and take consideration for when we're caring for any patient with a fracture. Okay, so let's talk complications. Early on, what can go wrong? Okay, our first priority complications we're going to assess for is shock, fat embolism, which is most commonly linked to a long bone, compartment syndrome, and then we've got VTE and PE. Super important is that neurovascular assessment. Neurovascular assessment, it means we have to be sure we're checking pulses to all extremities, but especially the one that is affected and distal to the fracture site. We have to do this neurovascular assessment, especially if they complain of numbness and tingling, or if their extremity is cool to the touch, because these are symptoms of compartment syndrome. Let's see, I think where I want to go next is on the next slide. So if they have shock, what are the early versus late symptoms? So this is when, this circles back to last unit, the PACU unit, when we had frequent vital signs because they were recovering from surgery. This is one of the things that we were considering. What if they go into shock? There's 5 different types of shock, and we don't need to, at this point in the game, know those 5 types. What we need to be able to do at this term is identify the early signs so that we take action before they get to the late signs, because shock is deadly. So early on, their blood pressure isn't going to change, but guess what? That heart rate's going to go up. Their skin color may look normal, but their temp may be cool and moist. They may be acting differently. Restlessness, anxiety, increased respiratory rate and depth. Those are those early symptoms. Those we have to lay eyes on our patient and do a quality assessment to catch these early signs. Okay, so those are the key things for shock. And then, of course, as it progresses, we've got their systolic blood pressure is going to drop. Their heart rate's going up, but it's now weak. Their skin is now pale. They're now not cool. They're cold. They're no longer conscious. And their respiratory rate is high, but it's very shallow. Those are the worst. Those means things have deteriorated. So then I said DVT, we have to assess. So these are the 3 things that come into play for formation of a DVT to occur. So you've got venous stasis, a vascular injury, and hypercoagulability. So whenever you have a fracture, it is prime time for a DVT. So we have to be diligent in assessing peripheral pulses, circulation, temperature, all those things. It ties right in with the VTE, which is another word for DVT, deep vein thrombosis versus venous thromboembolism. And then we also have to throw in that fat embolism. Remember, you want to think long bone fracture for a fat embolism. So femur, hip, that sort of thing. With DVT and VTE, also smokers. Smokers are at high risk for this. If they're less mobile, if they're older adults, or if they have any circulation issues, again, higher risk for those DVTs. If they say they have unusual pain, confusion, fast breathing, if they are short of breath, lightheaded, or restless, we need to narrow in which one of these is happening. And we may not be able to determine which one of these is happening, but we can know that something is going wrong and take action. Okay. This slide, I talked about compartment syndrome and how our nerves and blood vessels flow through these compartments and it's contained within fascia. And so if something goes wrong in one of those compartments and pressure builds up, nerve and blood flow can be cut off, and then tissue death occurs. And that is why this is an emergency situation. So this is just to give you an example of how each little portion is its own little compartment, like a little section that has to be working right. So if there's a problem in a section, we have to take steps very quickly in identifying it, notify the healthcare provider because they're going to need emergency surgery to relieve that pressure and restore blood flow and nerve function. This slide is just an example of the different ways that we can internally fix a hip fracture. And then this slide, some, in a nutshell, key things for hip fractures. So they're going to be immobile. We're going to probably do surgery with an internal fixation. Okay, we are going to do that. Who's at risk? Advanced aged, female, history of osteoporosis, postmenopausal, and if they fall a lot. And this is that classic symptom of hip fracture I was telling you about on a previous slide. See how the leg is shorter and rotated out. That is the classic symptom that there is a hip fracture. So keep them still, keep them immobile, and get a help. After they've had their hip fracture repaired, what do we need to do? We've got to have them cough and deep breathe. We've got to prevent DVTs. We've got to prevent that hip from going out of its location because it's not going to be healed. So we use a wedge pillow to maintain leg abduction. We have to do circulation, neuro, pain control. We want to get them up out of bed the first post-op day. Early ambulation is key. And then dressing changes and assessing underneath our patient. Let's see. And then I think this is our last topic. If you're taking care of a patient that has an amputation. So amputations can occur for a variety of different reasons. It's typically used to relieve symptoms, improve function, improve their quality of life overall. So their life will be better without whatever portion of the body has been removed, ideally. These are the most common places for amputations, and I would say legs are far more common than arms. There are some specific care considerations that are included on this slide for stump care, and then like immediate post-op, and then for long term. So the stuff on kind of the peach pink side, you have to maintain good function above the amputation. We need to talk with them how they may still feel pain even though the limb is gone. Use analgesics appropriately. Keep a close eye on the healing. They're going to have compression dressings because swelling of the stump is a common problem, and they'll have this compression hose that they put over their stump to help encourage good circulation and prevent pooling in their stump, which will hurt and will cause wounds if we don't prevent it from happening. And then they're at high risk for bleeding just because we had to go through some large vessels and to create the stump itself. After it's healed, we're going to watch for infection, watch for pain, wear their prosthesis, safe mobility, and we don't generally put anything on the stump. So no lotion, no alcohol, that sort of thing. Okay? And I would say we want to prevent any further loss of circulation promote comfort and mobility. Those are our care considerations when caring for someone that's status post and amputation. Okay, so that brings me to the end of this unit. Thank you so much for listening. I know we went through a lot of information. I appreciate your time, and let me know if you have any questions. Thank you so much.